So what is flow cytometry? Well, flow cytometry is a very powerful technique for the analysis of single cells. It's one of the few techniques that really allows one to look at single cells and gain a lot of information about each of the individual cells. It's inherently multiparametric so that one can look at multiple different facets of a cell all at the same time on an individual cellular level, which is a very unique aspect of this technology. In addition, one can acquire this information very rapidly in a very quantitative fashion. As a platform for assay development, flow cytometry is extremely flexible, which is both a benefit and kind of a curse for the technology historically. It allows one to develop assays that are robust and very informative, but it also makes it possible to develop assays very simply, which are often not particularly well validated. And this is one of the continuing problems with flow cytometry in general in a clinical laboratory setting. And as I just mentioned, flow cytometry really is a platform. It's not an assay per se. There's a lot of things you can do with flow cytometry. So simply writing flow cytometry on a tube of blood and sending it to the laboratory doesn't tell the laboratory what you are supposed to do with that tube of blood. There are a lot of different things that can be done, and each of these assays requires validation and examination of its performance characteristics, such that there are a lot of different assays that are used in the clinical laboratory environment, such as lymphocyte subset analysis, which was really the first assay that brought flow cytometry to the clinical laboratory. CD4 positive T-cell enumeration became very important during the HIV epidemic and really was the application that brought this technology to the lab. Other assays that are commonly done in a clinical setting include things like immunodeficiency evaluation, the enumeration of stem cell populations, particularly CD34 positive stem cells, paroxysmal nocturnal hemoglobinuria diagnosis, where flow cytometry is really the diagnostic technology for making that particular diagnosis. And one can measure reticulocytes, fetal erythrocytes, do HLA cross-matching, and there's an ever-expanding list of these types of applications that are suitable for the clinical lab. The one we're going to spend more time talking about today is one of the most difficult applications, but also one whose use is increasing most rapidly, which is the evaluation for leukemia and lymphoma. Now, leukemia and lymphoma analysis is somewhat unique among the different types of things that can be done by flow cytometry. Most of the other tests that we were just mentioning are tests that are based on the identification and enumeration of a population of cells whose phenotype is very well known. You know exactly what it's supposed to look like, and you can easily identify it and enumerate it. For instance, CD4 positive T cells express CD4 at a uniform and constant level, regardless of the person that we're talking about. When we come to leukemia and lymphoma analysis, this is not the case. What we're trying to do is to identify the presence of an abnormal population of cells whose immunophenotype is to a large extent unknown. In fact, we don't even know whether this population is actually present in the sample or not. That's our initial task. In addition, multiple of these abnormal populations may be present in any given sample at the same time. So this particular type of analysis requires a lot of more detailed evaluation of data and a lot of hunting and searching to identify the presence of these abnormal populations, at least as is currently practiced. In addition, for leukemia and lymphoma analysis, we're actually asking a number of different overlapping kinds of questions, such as, is an abnormal population actually even present in the sample? Yes or no? If there is an abnormal population present, then what is the lineage of that population? Are these B cells, T cells, myelomonocytic cells, etc.? And what's their maturational stage? Are they relatively immature? Are they relatively mature? Are they somewhere in between? And then how does that information then allow one to further classify a particular neoplasm? And finally, once one knows exactly what type of neoplasm is being dealt with, are there prognostic markers or factors that can be evaluated to give someone an idea about how this person is likely to behave? And all of these questions have to be answered quickly and efficiently and in a complex cellular background. So this is why this type of analysis is really one of the most challenging applications of flow cytometry. When we talk about identifying abnormal populations, the reason that we can do this at all is based on the fact that as hematopoietic cells mature from the stem cell population through to committed progenitors out to later stage forms, they follow a genetic program. And this genetic program is highly controlled, highly regulated, and results in the expression of proteins in a very highly regulated fashion as well, such that for each stage of maturation of these cells, there's an antigenic profile characteristic of that cellular stage of maturation or differentiation that's pretty much invariant from person to person. So there essentially is a normal immunophenotype for each stage of maturation. When cells become abnormal or neoplastic, there are alterations in this pattern of genetic expression that control maturation and differentiation, such that we now have abnormalities in protein or antigen expression that can be measured by flow cytometry, either on the surface of the cell, in the cytoplasm of the cell, or in the nucleus. And these types of abnormalities can be grouped into a few different basic categories. For instance, one can find increases or decreases in the expression of antigens which are normally expressed by a particular population. So at that particular stage, the cell may express, for instance, an antigen CD13, but the level of expression of CD13 may be abnormally high, it may be abnormally low, or it may be completely absent altogether. There also are abnormalities in the timing of expression, so-called dysynchronous or asynchronous maturation, where a given antigen may be expressed at a particular stage of differentiation, perhaps on early cells, and when the cells become abnormal, that antigen may be expressed on more mature cells where it's not normally present. The expression is appropriate for that lineage of cells, but it's inappropriate in terms of timing for that given stage of differentiation. There are also antigens which can be, frankly, aberrantly expressed. These are things that should never be present on the surface of a cell or in the cytoplasm at any time during its differentiation, but because of the aberrant genetic program, these cells now have become expressed. And when this happens, this is fantastic because it makes our task really simple. It's a clear aberrancy, easy to identify. Unfortunately, it's not the most frequent thing that occurs. Typically, these other types of abnormalities are more common. And then finally, for some antigens, typically they're expressed in a more heterogeneous pattern with maturation. Particularly, the heterogeneity often reflects differences in maturational stage for this population. And when the cells become neoplastic, they very commonly will express these antigens in a much more uniform fashion, often as if the cell was arrested in terms of maturation. But the basic idea here is that by knowing in a great deal of detail exactly what normal maturation looks like at an antigenic level, one can identify deviation from this maturation as a marker of neoplasia. And that's really what underlies flow cytometry for the diagnosis of these types of disorders across the board, almost regardless of application. So one can make pretty graphs like this that kind of describe the different stages of maturation. This is taken from the chapter we wrote for Henry's textbook of lab medicine. And at the top, you can see the different stages of B-cell maturation, using B cells here as our paradigm. And there are three basic immature stages of B-cell maturation, which are being called immature early, immature mid, and immature late. And at each of those different stages of maturation, there are differences in the expression of multiple different antigens at each particular stage. So for instance, on immature early B cells, TDT is expressed in the nucleus, CD34 is expressed on the cell surface, and as those cells transition from that early stage to the immature mid population, both TDT and CD34 are lost. Similarly, at an early stage of maturation, CD10 is expressed at a high level, and with further maturation, CD10 expression declines. CD19 expression is expressed from very early stages all throughout B-cell maturation, but at varying levels of intensity, etc. But if one looks at any particular stage of maturation and chooses an appropriate combination of reagents, one can identify very specifically that stage of maturation and define its normal immunophenotype. One can then take that information, select a panel of reagents, and run it on clinical material. And this is an example of B-cell maturation being demonstrated by 8-color flow cytometry, where one is looking just at the CD19 positive B cells and is able to see the very tight correlation of the antigen expression present on many of these populations. For instance, there's a population that expresses out here CD10 at a relatively high level, CD45 at a relatively lower level, and as the population matures, the level of CD10 declines slightly as CD45 increases. There's a third stage of maturation up here where CD10 is expressed at a dim level, CD45 is now as bright as that on a mature lymphocyte, and then CD10 is lost. But the point here is that the antigen expression is highly correlated. It's not random. At each stage of maturation, there's a distinct immunophenotype that can be easily appreciated. And it's knowledge of these patterns of normal antigen expression that form the framework on which we can then identify abnormalities. For instance here, so this is a case of precursor B-cell lymphoblastic leukemia. And what one can see is that knowing what normal maturation looks like, one can identify that this red population is both closely related immunophenotypically to normal immature B cells, but yet deviates from that in a number of substantial ways. So for instance, the level of CD45 expression that's present on these cells here in the top left is abnormally low compared to what we just observed for even the most immature cell in normal B-cell maturation. The level of CD19 is also slightly decreased in intensity. The level of CD10 is aberrantly increased in intensity. These cells are aberrantly expressing at a low level CD33, a myeloid-associated antigen, as well as CD13, an additional myeloid-associated antigen. And the cells indicate their immaturity by the bright overexpression of CD34 with essentially low to absent expression of CD38, when in fact this population should be located out in this area here. So the phenotype of the population is similar to that of a normal immature B cell, but yet deviates from that in a way that we can easily identify it as abnormal and make a diagnosis of an immature B cell neoplasm, in this case precursor B cell lymphoblastic leukemia, lymphoma. The same can be said for T cell maturation. We won't go through any of these in any detail, but just to show you that the same type of findings occur. Different stages of T cell maturation, different patterns of antigenic expression. Those can be done in multicolor experiments, in this case a 10-color experiment showing T cell maturation in the thymus. Similarly, for normal granulocytic maturation, each of the different morphologically identified stages can be easily identified using an appropriate combination of reagents based on their appearance or disappearance at particular stages of maturation. 10-color flow cytometric experiments can then be used to demonstrate the tight correlation of all these antigens throughout maturational stages. This is some data that we published a number of years ago, just demonstrating more concretely exactly the tight association of these antigens. The actual identification of the expression of these has been demonstrated over the last couple of decades by a number of different investigators. Same with monocytic maturation. At each particular stage, characteristic patterns of antigen expression, which can be demonstrated very nicely using a 10-color flow cytometric experiment. So it's this knowledge, detailed knowledge of normal maturation that really allows us to identify what's normal and identify what's abnormal. The same thing can be said by looking at even smaller compartments of cells. So if one takes a look at the blasts or the immature progenitors present in bone marrow, even within that compartment there's a great degree of information that's contained when one starts looking at this with a higher level multicolor flow cytometric approach, such as that one can identify the stem cell population, which is located, come here pointer, in any case, it's located with bright CD34 and low to absent CD38 expression, and right here. And as the cells mature, they acquire increasing levels of CD38, a slight drop in CD34, and then a complete loss of CD34, and eventually a loss of CD38. And each lineage of cells, as they mature from these early progenitors to later stage forms, follows a very characteristic maturational pathway, which we've now mapped out and can use as our normal template for normal maturation. So we can take all this information taken from all these different lineages that we're evaluating and put them together and use that information to make diagnoses of particular types of malignant neoplasms. For instance, here we're looking in the top row at normal differentiation in a normal bone marrow sample. The CD45 projection of this data for the normal sample shows the normal lymphocytes, monocytes, maturing myeloid populations, early myeloid progenitors, early B cell progenitors, and early erythroid progenitors. And in myeloid maturation, we get this nice relationship between CD13 and 16, characteristic of normal neutrophilic differentiation. And on monocytes, we get a nice pathway of maturation in purple, typical of normal monocytic differentiation. In this patient with myelodysplasia, one sees a marked abnormality in the CD45 side scatter pattern, with a loss of side scatter variably on the maturing myeloid population, indicating hypogranularity, an expansion of monocytes, indicating an immature monocytosis, and also in red, although it's difficult to see, an expansion of early progenitors, indicating an increased number of blasts. Looking at myeloid maturation, the pattern of maturation is clearly abnormal and different from that seen normally. And looking at monocytic maturation, similarly, there's a marked expansion of immature monocytic cells with very poor maturational progression. So this information taken together suggests, first of all, this patient has some kind of a hematopoietic disorder, and this constellation of abnormalities is very typical of what one finds in a myelodysplastic syndrome and allows us to suggest that particular diagnosis with a high degree of accuracy. So flow cytometry using this type of approach is very good for the diagnosis and the classification of a wide variety of different hematopoietic neoplasms. It's very good at identifying the presence of an abnormal population of cells, if it's present. It's very good at defining its immunophenotype, the lineage and the maturational stage, which then allows one to further classify the process. And it also is good at providing quantitation of the population. We can enumerate the number of those cells that are present over some denominator and estimate the degree of involvement. Now this is subject to some limitations in terms of sample quality and preparation, such that if we get a hemodilute specimen that's supposed to be bone marrow, obviously our quantitation isn't going to be as accurate. But nevertheless, for the sample that we have, flow cytometry is very good at quantitating what's actually present in that sample. And as such, the technique then has found a lot of utility and is increasingly popular for the diagnosis of hematopoietic neoplasms kind of across the board. So if one looks at hematopoietic neoplasms, where is flow cytometry informative? Well, it's usually informative in cases such as acute leukemia, both for identifying the fact that it's leukemia as well as defining the lineage and type of maturation. It's good for looking at non-Hodgkin's lymphomas, almost of all types. And one of the newer applications that we've published data on is the identification of myelodysplastic syndromes or other myeloid stem cell disorders, which are increasingly utilized for that particular diagnosis. There are a subset of myeloproliferative disorders where flow cytometry is also useful, although there are certain subclasses, particularly polycythemia vera and essential thrombocytosis, where flow cytometry doesn't do a particularly good job at this point of identifying those disorders, and molecular testing may be more appropriate. And then finally, there are a few outliers, disorders that historically have been difficult for flow cytometry to identify. In particular, Hodgkin's lymphoma has been one of these that's said to not be possible to identify by flow cytometry. But as you'll see in just a few minutes, because of our high-level multicolor capabilities in the laboratory, Dr. Jonathan Fromm, my colleague, has developed a very nice assay for the identification of Hodgkin's lymphoma that should move that assay up into the category that we would call usually informative. Also to reiterate, flow cytometry is not the end-all and be-all of diagnostic hematopathology. There are other things that need to be taken into consideration these days to make a diagnosis of a hematopoietic neoplasm. In fact, if you look at the WHO classification, the actual diagnosis is a multifactorial one, requiring integration of clinical history and clinical findings, morphology, immunophenotyping provided by flow cytometry or immunohistochemistry, and cytogenetics or molecular studies. So while flow cytometry is playing a very prominent role these days in the diagnosis of these disorders, the integration of this information is also key to make a definitive diagnosis for any one of these hematopoietic neoplasms. So by flow cytometry by itself, in most cases, doesn't allow for definitive classification of these disorders, although it's able to identify them very sensitively. An increasing use for flow cytometry, in addition to just diagnosis and classification, is to identify therapeutic targets. So molecules that might be suitable for use in a clinical setting. And there are certainly an increasing number of monoclonal antibody-based therapies that are used to treat hematopoietic neoplasms. Probably the most common of these is anti-CD20 therapy, or rituximab or Rituxan, that's almost uniformly used now to treat patients with B-cell lymphoma. One can easily detect CD20 by flow cytometry on the surface to determine whether or not the patient may be a suitable candidate for treatment by this type of expensive therapy. And one can use this information then to monitor the efficacy of therapy after the patient's been given this particular antibody. Similarly, for Mylotarg or anti-CD33 antibodies that are used to treat acute myeloid leukemia, Campath or CD52, anti-CD52 used to treat many forms of refractory lymphoma, anti-CD25, etc. So there's a growing list of these types of therapeutic agents where flow cytometry can help evaluate the presence or absence of a target prior to the administration of therapy and then monitor them after therapy. Coming down the road, people are beginning to look at a variety of other more sophisticated types of molecules that interfere with cell signaling pathways, for instance, where flow cytometry has been developed to be able to look at, say, phosphoproteins within these cell signaling cascades and be used to monitor the efficacy of therapy for those particular molecules. And this may find an increasing role in the clinical laboratory in the future. There are also efforts underway to identify reagents that are suitable for the identification of translocation products. In many hematopoietic neoplasms, chromosomal translocations are a common factor, and the products that are produced from these translocations, in theory, should be able to be assayed by flow cytometric methods, and there are companies actively working in this area. Any of these assays that are being looked at are largely being driven by therapies which companies, drug companies or others, are looking to implement clinically, and so methods are needed in the clinical laboratory environment to monitor these particular therapies. And so this is a very active area of investigation at the moment. Another potential or current utility for flow cytometry in a clinical setting is the post-therapeutic monitoring of patients after they've been treated. This falls into the category of what's often termed minimal residual disease detection. And there's a growing literature on this type of activity. This is a particular area of interest that we've had over the years, and in fact we serve as the national reference laboratory, one of two, for the Children's Oncology Group for the monitoring of children with acute lymphoblastic leukemia. So we get a few thousand samples a year where we're looking for minimal residual disease in this particular subgroup of patients. We also participate in studies with the Southwest Oncology Group of a similar sort and do a large volume of clinical testing both within and outside the institution for this particular indication. This is a growing and very important area of use of flow cytometry in the clinical environment now. The idea here is that as patients are treated for their hematopoietic neoplasms with usually induction chemotherapy, that there hopefully will be a decline in the number of neoplastic cells that are present in the patient. In some patients, this decline will be relatively small, and the patient will then very rapidly, even during the course of consolidation or other therapy, recur with frank relapse with a high percentage of neoplastic cells. In other patients, the number of abnormal cells will decline much more greatly and may fluctuate at a very low level for an extended period of time, only to relapse at some later date. There also are a subgroup of patients who are treated effectively by the therapy and whose disease goes to a very low level, potentially undetectable, and then never relapses and are essentially cured of their disease. And we'd like to know at an early stage of therapy who these patients are and which subcategory they belong, so that we can affect changes in their therapy that might create cure for a larger percentage of patients. And this is one of the goals of minimal residual disease detection. So the idea behind this technique is to detect residual neoplastic cells after therapy, which hopefully will be small in number and therefore constitutes a type of rare event analysis. The purpose here is to assess adequacy of response, to predict relapse, and to help guide therapy, either to change therapy, to give more aggressive therapy, or the like. The strategy really is no different than what we would do for the diagnosis of hematopoietic neoplasms at the beginning. The only difference is that the level of this neoplasm now is present at a much smaller level, and so one needs to pay much more attention to technical details in particular related to the performance characteristics of the instrument, of the reagents, and the way in which one analyzes data. We're still going to look for abnormal populations and relate them to the most similar normal population that we can identify based on their lineage and maturational stage. We're going to use their basic extension of diagnostic immunophenotyping to identify the nature of deviation that's seen at diagnosis and use that information to help guide our subsequent evaluation of the specimen, although we won't rely on it exclusively. And this requires also a detailed knowledge of normal maturational patterns for all of these different cell lineages. So for these reasons, this is a much more demanding form of analysis. This is just an example taken from our laboratory showing a person who was treated for acute lymphoblastic leukemia and who has residual disease. The residual population is colored red, and the normal immature B-cell population, whose phenotype is somewhat similar, is colored in light blue. And what one can see is that although the immunophenotype of this abnormal population is similar to that one might see normally, in that it expresses things like CD10, the level of CD10 is expressed at an aberrantly high level in comparison to normal B-cell maturation here below it, where both CD10 and 20 are being acquired in a normal pattern of maturation. In addition, the level of CD58 is being slightly overexpressed in comparison to normal. The level of CD45 is being aberrantly underexpressed and in fact is entirely absent on this population in comparison to even the most normal immature population. The level of CD38 is actually close to normal, and the level of CD34 is slightly decreased. This composite immunophenotype allows us to very specifically identify this population of cells as being abnormal, having an immunophenotype similar to that of a normal immature B cell, and to be indicative of residual disease after therapy at the level of about 0.1% of all the abnormal cells. This is a level of involvement that's far below that one might actually see if one was looking under a microscope, where the limitation is somewhere in the range of 1 to maybe 5% of abnormal cells. Flow cytometry is capable of going down to much lower levels of detection, and we routinely detect disease down in the range of 0.01%, and in some cases down to 0.001% of all cells evaluated. Similarly, in acute myeloid leukemia, here we have a patient that's been treated. At diagnosis, the immunophenotype is typical of AML in that we have a large expanded progenitor population on 45 side scatter. This population is immature, as evidenced by the expression of the immature antigen CD34, and has aberrant low to absent expression of CD38, overexpression of c-KIT or CD117 with a little bit of myeloid maturation antigen CD15, and uniform expression of the two myeloid-associated antigens CD13 and 33. After therapy, the size of this population after 2 weeks is down to 8.8% of all the white cells from 56.3%, and the phenotype is similar but is beginning to change. The high level of CD117 that was seen at diagnosis is now virtually absent, and CD15 has been more uniformly acquired, and the levels of CD13 and 33 that were present initially have now both decreased in intensity. By 4 weeks after therapy at day 32, or the end of induction, this population now represents 0.2% of the white cell population, has a similar abnormal expression of CD34 and CD38, but now is essentially virtually absent expression of CD117, much more uniform expression of CD15, and virtually absent expression of both CD13 and CD33. So by using a multiparametric approach, we're able to identify the presence of this abnormal population even though the immunophenotype of the population is changing over the course of therapy. And that's a very important aspect of minimal residual disease detection that's not always appreciated in some other laboratories doing this type of evaluation. What is the significance of doing this type of detailed work? Well, there's a variety of studies, both in acute lymphoblastic leukemia and in acute myeloid leukemia, showing that this information is highly prognostically significant. In this case, the study published by Morfau and his group from Spain shows that depending on the level of involvement at the end of induction chemotherapy, so at a single time point following chemotherapy, one can stratify patients based on the level of disease into groups having significantly different probabilities for outcome or relapse, with the high levels showing relapse or death at a very rapid rate, the patients that have no detectable disease being essentially normal or living for the usual expected time. So for this reason, clinicians have now become to essentially demand the use of minimal residual disease analysis in evaluating patients with acute leukemia. And this is the type of work we're involved with both the Children's Oncology Group and the Southwest Oncology Group. So residual disease after therapy is prognostic for relapse, and it's increasingly being used as a surrogate for response in clinical trials. So instead of waiting for the patient to actually relapse, which might take years to happen, one can use the decline in the level of disease early on in therapy as a surrogate marker for response and plan one's clinical trials based on this information. And it's becoming an increasingly important factor of MRD usage for clinical trials. This is also being increasingly used clinically by people both within the university setting and to some degree out in the community as ways to decide whether the patient needs additional therapy or to time additional therapy such as the use of bone marrow transplantation. But it is more demanding than typical diagnostic immunophenotyping, and so there are quite a few laboratories, particularly out in the community, that don't offer this technology at this point but are actively thinking about becoming involved, which is an issue we'll come back to in terms of standardization in just a minute. So what is the current situation out there in the community in terms of the way flow cytometry is performed? Well, most laboratories in the community currently do what we call 3 and or 4 color flow cytometry, meaning they're able to evaluate the expression of 3 or 4 antigens simultaneously on abnormal populations of cells. There are still some laboratories out there that are performing 2 color flow cytometry, despite the fact that the consensus recommendations from the mid-90s indicate that this type of work requires that at a minimum 3 color flow cytometry. But these labs are still out there. The testing volumes for flow cytometry, however, as a result of the increased recognition of its utility, are increasing fairly rapidly, and our volume continues to increase at a rate of at least 15% or so a year for the last 5 years. So the technology is important. It's providing useful information to people, but there's still a lot of heterogeneity in terms of the way people are going about doing this. At the same time, new instrumentation is becoming available. And one of the things that our laboratory is known for is we were one of the first, or the first laboratory in the world to put online a higher level of multicolor flow cytometry, where our standard now is to do 10-color flow cytometry routinely on clinical material. And we've done this for a number of years now. Other laboratories are starting to migrate now to doing 6 and 8-color flow cytometry as newer instrumentation becomes available. So increasing numbers of labs, particularly in academic setting, have instruments like this, but they're having difficulty getting these instruments online and validated, such that they're still largely transferring their 4-color panels to 6 or 8-color instruments and then thinking in the future about trying to develop new assays. And so there's the need for assistance in terms of the discovery and validation of panels of reagents suitable for use in these contexts. One of the reasons why we were so interested in going to a higher level of multiparametric flow cytometry is that we wanted to provide more accurate population identification. As you've seen, the type of work that we do, particularly for residual disease detection, relies on accurate population identification, which this multiparametric approach really facilitates. So the more parameters, the more definitively you can identify any particular cell or group of cells as being normal or abnormal, just due to the greater informational content that's present. In addition, it should allow us to make better use of small specimens. We're going to set up fewer tubes of reagents. There are going to be more reagents per tube. So specimens that are limiting in terms of the number of cells, for instance, fine needle aspirates, CSFs, or body fluids, where cells really are a limiting factor, we can get a lot more information out of these samples than we have historically. It also allows us in the lab to process fewer tubes of sample so that we can save on reagents, ultimately, on tech time and on instrument time, all of which are in short supply in a busy clinical laboratory setting. And because we're processing fewer tubes, it'll allow us then to acquire larger numbers of cells on the instrument, which is very important for minimal residual disease detection. In part, the sensitivity relates to the number of cells acquired, and so if you're going to be doing a lot of this, you're going to be collecting a lot of events. Processing fewer tubes, running fewer tubes on your instrument will allow this to happen much more efficiently. And as we'll talk about in a minute, ultimately, hopefully, by using a higher level multicolor approach, one can then help standardize clinical flow cytometry. So how many colors are enough? How many do you need to do this kind of analysis? Well, ideally what we'd like to do is take everything we want to run and stuff it into one tube, and that would be fantastic. Perfectly correlated data. We wouldn't have to do anything more than a single tube of reagents. Unfortunately, if you've looked at the WHO classification of hematopoietic neoplasms, it's a book. Okay, there are like 75 or more different kinds of neoplasms, all of which have slightly different immunophenotypes. There's really no way we're going to be able to do this realistically. So what's probably more realistic is to look at each of the different lineages that we normally evaluate, because our approach here is to look at normal maturational patterns, which are often lineage associated or relatively lineage specific, and design combinations of reagents that are relatively comprehensive to identify the presence of an abnormal population of cells for that lineage, but may not allow its classification to the nth degree without the use of a secondary panel. This is in part based on the knowledge that roughly half of the samples that come through a clinical laboratory are essentially negative for the presence of hematopoietic neoplasm. So we want to screen these samples efficiently, identify the ones that are negative so we can put them aside and not work on them any further, and focus our more intensive efforts on those that actually have something to be evaluated. So the focus here really is on creating a set of screening tubes specific for different lineages of cells. So if you ask how many antigens typically are used to evaluate a B-cell population in a reasonably comprehensive fashion, you get a list of reagents that looks like this: CD19 and 20, immunoglobulin light chains kappa and lambda, CD45, CD5, 10, and 38. So we're up to eight antigens already, so we're talking 8-color flow cytometry. Yet look at the T cells, a similar fashion. CDs 2, 3, 4, 5, 7, 8, 56, and 45 are commonly used to evaluate T or NK cell lineages. We're up to 8-color flow cytometry already. So very early on, as we were thinking about moving to the next level of instrumentation, we looked at the instruments that were available. These were the two instruments that were currently on the market or would shortly be on the market: the Beckman Coulter FC500, that's a 5-color instrument, and the Becton Dickinson FACSCANTO, which is a 6-color instrument, and said, neither of these instruments has a sufficient number of colors to do what we want to do. So what do you do when you can't buy the instrument that you want? You make it yourself. So we went to the different manufacturers and we said, we want an instrument, custom made, that can do this level of flow cytometry. And to their credit, eventually Becton Dickinson said, we'll build you this instrument on a custom basis. And this instrument, after a few rounds of modification, is now what you can commercially buy as the BDL SR2. But a lot of this work had its origins from our impetus asking for an instrument of this sort, and now is a commercial product. The instrument that we currently use in the laboratory is a 4-laser instrument, having a violet, blue, red, and yellow laser on it. Each of them separately intersect the flowing stream of cells, so-called spatially separated lasers. Each of them then have fiber optic collection devices which allow the light to be funneled to a series of detector arrays, having the number of detectors indicated here. They're processed through a series of custom-built digital electronics, and then most of the work is done in the computer. We currently have 2 of these instruments in the laboratory that are really our workhorses for leukemia and lymphoma analysis, and we now have a 3rd instrument that will be delivered next week. And I have to really give credit here to Dr. Fine for being the one years ago when I came up with this idea, who was willing to have the foresight to recognize what the potential utility was and fork out the big bucks that it required at the time to purchase this first instrument. Because this instrument didn't exist and we didn't know what it was going to do, and it was expensive. So I really give him credit, because basically everything that's happened in the lab since that time is built on this foundation of having acquired this technology. So what this enabled us to do then, once we had the instrument up and validated, was to take our 4-color panel, which looks something like this, 2 B-cell tubes, 2 T-cell tubes, and a series of myeloid tubes, so essentially 10 tubes together, and condense them into a series of 4 tubes that are pictured here. And each of these tubes is based on the idea, as we discussed, of identifying abnormalities in a particular cell lineage. So we have a single tube that looks at B-cell maturation. We have a single tube that looks at T-cell maturation. We have a single tube that looks at maturation of progenitors from stem cells to committed precursors. And we have a single tube that looks at myelomonocytic maturation to later stage forms. So for a particular sample that comes into the laboratory, we don't necessarily run all of these on every sample, but based on the medical indication, we can pick and choose which combination of these tubes is appropriate to identify abnormalities in each particular lineage. So if the patient, for instance, has a history of a B-cell neoplasm, we can simply run one tube, the B-cell tube, collect a large number of events, and with a high degree of sensitivity say whether or not that person has disease or not. And if there's nothing there, we're done. Just to give you an idea of the informational content that can be generated from this type of approach, this is a combination or a representation of all the 15 unique combinations of antigens and light scatter parameters that are present in a 4-color experiment. This is the level of information in a 9-color experiment. Okay, there's 55 unique combinations. This goes up at a geometric rate. So the amount of information that you're gaining by adding additional colors goes up quite rapidly. Now, this, of course, represents a challenge in terms of data analysis to try and make sense out of the information that's been acquired. And this is, in fact, one of the ongoing efforts of the laboratories to identify software algorithms that allow for the efficient and hopefully ultimately automatic identification of abnormal populations of cells. But it's through the standardization of the technique to allow this level of information to be acquired that I think this will be ultimately achievable. So one can take the seemingly complex information and approach it as we would any other type of data analysis and identify abnormal populations at a low level in samples fairly readily. So all the information that's here is a very small subset of one tube that was run to look at B cells, and one can easily identify the abnormal population with some experience. Located down here, come here arrow. It's on the bottom left panel showing the expression of CD10 and CD20, the little blue cloud that's present, unlike the mixture of blue and red events that are present. And the histogram or dot plot next to that shows the same population expressing both CD10 and CD38, etc. This is a kappa light chain restricted, which is why it's colored blue, population of abnormal B cells that's present in this patient's bone marrow at a level of 0.1%. It's actually very easily detectable when one uses the appropriate combination of reagents with a reasonably high degree of sensitivity. The same kind of analysis, however, can be done on specimens that have a much smaller number of events. So for instance, this is cerebrospinal fluid from a patient that's been diagnosed with B-cell lymphoma. It's a very paucicellular specimen. Nevertheless, we're able to identify a population of cells which is located, well, there we go, down here, having a high level of expression of CD20, absence of CD10, and a larger cell size. This is large B-cell lymphoma involving the cerebrospinal fluid, which we can pick out at a level of about 0.8%. So this is at a level that's essentially submorphologic in a very paucicellular specimen using one tube of reagents and inquiring all the cells that are present. So we're getting down to minimal residual disease levels of detection in paucicellular material. It's an accomplishment. One can also do other things, such as identify plasma cell neoplasms. So we have a single tube that we use to look at plasma cells, and we can fairly readily identify the plasma cells by their bright expression of CD38, which one can see in the top center panel here. One can look at cytoplasmic light chain expression, either lambda or kappa here, colored red and blue, and look at different plasma cell subpopulations. And in particular, there's a subpopulation here that expresses CD56 aberrantly, has aberrantly lost CD19 expression, and is all colored blue because blue indicates kappa light chain restriction in the cytoplasm. That's a clonal abnormal plasma cell population, unlike the rest of the plasma cell population here, which expresses CD19 and lacks CD56 expression, with polyclonal light chain expression as indicated by the mixture of blue and red dots. In addition, one can include a DNA binding dye, in this case DAPI, and identify that in addition, this abnormal plasma cell population, unlike the diploid plasma cell population here, has an increased DNA content typical of aneuploidy. So by looking at a single tube of reagents, we've picked out an abnormal plasma cell population, distinguished it from normal at a level of 0.05%, and we can say definitively that this is both clonal and aneuploid. And this is our common methodology now for use in the clinical lab, but this is not common in most clinical environments at this point. This technology, in addition to making more efficient the diagnosis of the usual types of hematopoietic neoplasms, offers the possibility of new assays that might be developed. So for instance, Hodgkin's lymphoma cannot be routinely detected by flow. And there are a lot of reasons that people have given over the years as to why this might not be possible. But it never made any sense to us that this is the case. But by using a 10-color approach, Jonathan Fromm in our lab has been able to develop an assay, first recognizing that when one takes a Hodgkin cell line, which is indicated by the middle row of figures here, and combines it with normal reactive lymph node, that these Hodgkin cells, indicated in red, which normally lack the expression of T cell antigens, in the presence of normal T cells, cause T-cell adhesion to the neoplastic cell, resulting in an aggregate or composite immunophenotype that's typical of Hodgkin's lymphoma. Having recognized that, he developed a very nice assay, 10-color assay, to develop the ability to detect these Hodgkin cells within a normal background. We sorted these cells and showed that they are in fact Hodgkin cells by usual morphologic criteria. In fact, one can see the adherent lymphocytes that are present in some of these specimens after cell sorting. And then went on to perform a large-scale validation study looking at 219 cases of tissues that had either Hodgkin's lymphoma, reactive conditions, non-Hodgkin's lymphoma, etc., and showed that this technique has a diagnostic sensitivity of about 90% with a diagnostic specificity of 100%. So we've taken an assay that essentially could not be performed and was thought to be undoable, and have now converted it using a multicolor approach to an assay that's now suitable for routine clinical use. And in fact, we just put this assay online in the last couple of weeks. This brings up the issue of standardization as well. At this point, leukemia and lymphoma evaluation is by no means standardized. In fact, it's very not standardized across the country and across the world. Different methodologies are used for sample preparation. The instrumentation that's used ranges anywhere from 2 to now 10 color. Different reagent combinations are used. Different methods of data analysis and reporting are performed. This is, if you look at an assay that's not standardized, this is the prototype for it. There's no standardization here. And this results in a huge variability in quality in terms of what's done in a clinical laboratory. Some labs do a very good job. Some labs do, I think, an actually very poor job of this type of technique. As a result, there have been attempts at various consensus conferences that have been formed, including the original one in 1995 that produced some guidelines for the performance of clinical flow cytometry for leukemia and lymphoma, an update in 2001 to attempt diagnostic reagents. But in a certain sense, both of these were failures in the sense that they never really devised a truly standardized methodology and validated its performance. And as a result, the field continues to languish in this state. So to this end, myself and a couple of other people put together an international consensus conference in Bethesda about a year ago to look at medical indications for performing flow cytometry, to identify reagent combinations suitable for performing flow cytometry for this indication, how these results should be reported, and what kind of training of people we'd like to have in order to do this type of work. I was put in charge of the last three categories, looking at reagents, reporting, and training. What resulted from the reagent portion was this. If one looks at, well, we had initial discussions about reagent combinations from which there was, again, no consensus. So we conducted a survey, and we asked people for a given medical indication, and for each cell lineage, major cell lineage that was to be evaluated, which set of reagents would you run? And as you can see from this table, there actually is a high degree of consensus in terms of the reagents that people would use for particular types of medical indications. The real variability is within when you would run a particular or evaluate a particular lineage at a particular medical indication. So by this process, we were able to achieve a level of consensus that hadn't been achieved previously and identify a list of medical indications and the actual lineages that should be evaluated, both for routine phenotyping as well as for residual disease follow-up, and create a combination or a list of reagents that would be suitable to evaluate each of the different lineages. Okay, this isn't a panel that you can take and put on an instrument and run at this point. This is simply a list of reagents that people agree should be able to identify hematopoietic neoplasms. The next step in this process is to develop an actual reagent panel. An 8-color panel is currently under development, and perform an institutional, multi-institutional validation study to show what the true sensitivity and specificity are of this panel of reagents. Then, when this is done, to do a post-validation laboratory training exercise to bring people in and train them to do this methodology so it can be disseminated to laboratories throughout the world. This project is currently in the planning phases. I will be the PI of this project, and we've achieved funding from the Wallace Coulter Foundation, who's willing to fund basically whatever it will take to cause this to happen, which will probably be in the order of $1 or $2 million. And so this will be a major effort over the next couple of years that we'll be spearheading in order to try and standardize clinical flow cytometry for leukemia and lymphoma evaluation. The reason why we're doing this is that unless standardization is achieved in this area, further assay development is essentially going to be irrelevant. Because if the current situation continues, this technique will not obtain widespread acceptance like it should. There's already pressure from regulators, from payers, and physicians who look at the technology and say, we want to pay you for doing flow cytometry for leukemia and lymphoma, but how much should we pay you? And we can't go to them and say, here's how you do the technique, you should pay us this amount to do it, because this is the way it should be done. Everyone, ranges across the board from a few reagents to a large number of reagents. It's pretty much chaotic. In addition, the CMS and other regulators are looking at this with similar ideas in mind of restricting payment in an inappropriate fashion, and standardization has got to be achieved. And so this really is a major effort in the field at this point. And it's one of the major initiatives now that I'm Vice President of the Clinical Cytometry Society that we're actively pursuing. Another opportunity that's arisen in this regard is to develop a new reference method for doing white blood cell differential enumeration. So currently, the standard methodology for evaluating white cell differentials, if you're doing instrument evaluations in the laboratory or by instrument manufacturers, is a manual 400 cell diff off of a smear. And it's been that way for quite some time. Very tedious, very time consuming, also relatively inaccurate. So the International Council of Standards in Hematology has mandated that they would like a new reference methodology for this purpose, in part to extend the white cell differential to include populations of cells that aren't in the normal 5-part differential that we currently report, things like nucleated red cells, blasts, plasma cells, etc., and to allow for improved hematology analyzer validation and development. The manufacturers are particularly keen on this. The only technology that really has this capability at this time is flow cytometry. So as a result, I've also been put in charge of this study. It's going to be a multi-institutional validation study. The hematopathology lab is helping develop the methodology as we speak. I'll be the PI, again funded by the Walter Coulter Foundation, and we will develop a new reference method for doing white cell differentials that will become the new predicate method for this type of evaluation. This is just an example of an initial panel. The data was actually just collected yesterday, showing that in a single tube of sample using this particular reagent combination, one can easily identify the basic major subsets of white cells, including monocytes of a couple of different varieties, which are colored in purple, the maturing neutrophilic cells colored in green, immature myeloid cells, which are colored in red, eosinophils in orange, lymphocytes in blue, etc. And so this assay will work. It's simply a matter of nailing down the exact panel of reagents and then disseminating it for the multi-institutional study. So that's an active ongoing project as well. So the future of this technology, there are a number of things where flow cytometry may play a role. For instance, it's now well recognized that most hematopoietic neoplasms result from a stem cell-like population that has the capability for self-renewal and self-regeneration. The phenotype of this population and therapeutic agents targeted at that population are going to revolutionize the way many of these disorders are treated, and flow cytometry should perform an ideal tool in order to evaluate and identify and monitor this particular population of cells once we identify the tools that might be appropriate. There's also increasing amount of information about alterations in cell signaling pathways in a variety of hematopoietic neoplasms. And the evaluation of cell signaling pathways that control proliferation, apoptosis, and differentiation are now doable in a higher level multicolor context. So you can monitor whole networks of pathways at the same time and monitor therapeutic response. That's coming. Genetic abnormalities that are identified by techniques such as CGH arrays or gene expression arrays identify new protein targets, which flow cytometry is the ideal technology to monitor. And the actual host response to neoplasia may play an increasingly important role as well in understanding why patients that have relatively low levels of residual disease remain in remission for years at a time, whereas other patients with low levels of disease may relapse. So in conclusion, I'd like to say multicolor flow cytometry is an increasingly important tool in the diagnosis and monitoring of hematopoietic neoplasia. And high-level multicolor flow cytometry, such as the 9 or 10 color approach that we use in our laboratory, can be successfully performed in a clinical setting. We've demonstrated this over the last 2.5 years. It offers advantages in terms of efficiency, the use of small specimens, and the informational content that's provided. This approach also is ultimately going to allow for the standardization of a variety of different components of clinical flow cytometry analysis, in particular the diagnosis of leukemia and lymphoma, and provides an increasingly broad array of new opportunities for new assay development. And finally, I'd like to thank the Hematopathology Laboratory and my colleagues in the Department of Laboratory Medicine for the continued support of these activities over the last couple of years. Thank you very much.